Good morning, everybody. Happy Tuesday morning. Welcome to Grand Rounds. It is my pleasure to introduce this morning Dr. Erin Shaughnessy. Dr. Shaughnessy, as many of you know, came from Cincinnati Children's last year to head up our Hospitalist division here at PCH. She's been in that role now for just over 12 months. Dr. Shaughnessy is a native of Durham, North Carolina. She is a Blue Devil at heart. She went to Princeton University for undergrad and majored in English. She then went to medical school at Duke University back home, then did her pediatric residency at Cincinnati Children's Hospital. She started her career as an attending at the Medical College of Wisconsin, and as I said, came here to Phoenix Children's last year. She did receive a master's in science and healthcare management from Harvard in 2016. Since coming to PCH last year, she has thrown herself into a million different roles, and she is here this morning to talk about the evolution of pediatric hospitalist medicine. So please welcome Dr. Shaughnessy.
Thank you, Micah. I just want to apologize in advance. I'm overcoming laryngitis this week, so apologize if you have trouble hearing me. I will do my best to speak loud. It is my pleasure to talk about the evolution of the field of pediatric hospital medicine. This is a really exciting time to be a pediatric hospitalist, as we're essentially becoming a new subspecialty certified by the American Board of Pediatrics within the coming years. So the objectives today is I'd like to familiarize you all with some really exciting innovations that have occurred in the field of pediatric hospital medicine in the last decade. Explain the criteria for board certification in this specialty, and then really touch on the strategic vision of our division here at Phoenix Children's Hospital. So major innovations in hospital medicine. Some of these logos may be familiar to many of you. They represent some really incredible work that has occurred within the field in this last decade. So PRIS, Pediatric Research in Inpatient Settings, the VIP Network, Value in Inpatient Pediatrics Network, now part of the AAP, and then the Children's Hospital Solutions for Patient Safety, and IPASS, which actually is a research study launched from PRIS. So PRIS is a hospital-based research network that includes over 120 hospitals and over 800 participating hospitalists. It has received $26 million in extramural research funding over the past 8 years. And its stated goals are to improve the health of hospitalized children, define a national agenda for pediatric research, and to give better outcomes to hospitalized children. Some key accomplishments from PRIS have included the creation of PHIS+, which is a large database funded through a $9 million grant from the AHRQ that helps merge laboratory radiology and microbiology data with administrative billing data to really create a database to support comparative effectiveness research. Some of the early studies in PRIS that have recently been completed include a series of studies looking at the effectiveness of intravenous versus oral antibiotics for several serious conditions in children. These studies have included over 800 patients in 36 hospitals and have covered complicated pneumonia, osteomyelitis, and complicated appendicitis. So we look at this first study for complicated pneumonia. You'll see that there were over 2,000 patients included in this study. Most of those patients received oral antibiotics, and 281 received antibiotics through a PICC line. As you look at these results, you'll notice that treatment failure rates were very similar. Adverse drug reactions were actually slightly more common in the group treated with PICC line antibiotics, and the percent of PICC line complications for these patients was 7%. Obviously, there were no PICC line complications in children treated with oral antibiotics. And when you look at all related revisits to healthcare, including return to emergency room for PICC line related complications or adverse drug events, those types of issues, you're looking at a rate of 17.8% with those treated with PICC line antibiotics versus 3% for oral antibiotics. So this study really concluded that if there were oral options available for a child with complicated pneumonia, this was probably the safest and most effective option. Moving to osteomyelitis, again, over 2,000 patients, and this time the groups are roughly equivalent in those that received antibiotics via a PICC line versus those receiving oral antibiotics. Again, treatment failure rates were low and similar in both groups, around 5%. The rate of adverse drug reactions were also low. The rate of PICC line complications in this group was actually even higher than the previous group at 15%. And if you look at all treatment-related events, including return to emergency room, the rate was much higher in the group treated with PICC line antibiotics. So the authors concluded from this study that really clinicians should consider treating otherwise healthy children with oral antibiotics if an alternative was available. And this is mainly due to the magnitude and seriousness of complications of PICC lines. Next, we look at complicated appendicitis in children being treated with IV versus oral antibiotics. Interestingly, this study included over 4,000 patients at 35 children's hospitals, and the authors found a very high rate of variation between hospitals that routinely treated children with oral antibiotics versus those that used IV antibiotics. So the utilization of PICC line antibiotics ranged from 0 to over 90% based on hospital. And again, similar to the other studies, these authors found that the PICC group had higher rates of higher rates of treatment failure, I should say. This is the only study that found that. But then also had rates of complication that substantially increased risk of revisit. Adverse drug events were rare in both groups in this study. So overall, this group of work that came through PRIS showed that early conversion to oral antibiotics is as effective as prolonged IV antibiotic therapy and substantially safer due to fewer treatment-related complications with PICC line antibiotics. So this is really important work that is transforming how we care for children, potentially allowing earlier discharge from the hospital and treatment in the home setting, and reducing the need for return or reutilization of healthcare for adverse events. Another key accomplishment of PRIS is its work in really developing and mentoring young investigators within our field. It's a young field. So PRIS has really worked on mentorship networks as well as sort of faculty development offerings, workshops nationally. And 7 hospitalist investigators in the past 3 years have been able to leverage the PRIS network to go on to get career development awards either through NIH, AHRQ, or comparable organizations. So moving on to VIP, several of you in this room I know have been involved in this network. This is collaboration across multiple hospitalist groups and various places in the country to really improve incorporation of evidence into practice to help narrow that gap. And the collaborations have included discharge communication with PCPs, improved treatment of bronchiolitis, community-acquired pneumonia, and guideline-based treatment of urinary tract infection. Another organization that has really worked on quality improvement in the field is the Society of Hospital Medicine. Many of you may be familiar with the Choosing Wisely campaign. This campaign is really aimed to reduce waste in healthcare and to steer physicians away from doing things that are not effective. So I think a great example of this is a study that worked to reduce the use of pulse oximetry, which really has become quite commonplace since this technology became available. But reducing pulse oximetry can potentially encourage earlier discharge of patients and reduce rates of false alarms, which we all know can lead to alarm fatigue. Solutions for patient safety, I chose just a few of the conditions that this group works on. So Solutions for Patient Safety is over 100 children's hospitals in the country have joined this national network and have agreed not to compete on safety and to really share best practices across hospitals. And in doing so, these hospitals have agreed to send their data in centrally and really adopt best practice interventions and bundles that have come through the network. And for this, you can see over time, these are obviously very small, but the network has been able to substantially reduce rates of surgical site infections, catheter-associated UTI, and even adverse drug events. For this incredible work, the the organization was awarded the John Eisenberg Patient Safety and Quality Award through the Joint Commission in 2017. And I think many of you are involved in this work as well here. So we should feel really great to be a part of this incredible network. And the last innovation I want to touch on is IPASS. It's right now very familiar to everyone in my division, as we've really been working to incorporate this work into what we do daily. So IPASS is a multi-site educational research project launched through PRIS. So you can see PRIS isn't just about clinical or comparative effectiveness research, also active in educational research, and this can also be considered quality improvement research, quite honestly. But the key thing about this study is that unlike a lot of educational research, which strives to see if learners can report improved knowledge after an educational intervention, this study actually measured patient outcomes from an educational intervention, which is really powerful. And so the study group implemented a bundle of interventions to improve resident-physician communication around handoff, and as a result was able to quantify a 30% reduction in preventable adverse events, so produce medical errors that were reaching patients and causing harm. At the same time, they were also able to demonstrate that there were improvements in the actual verbal and written communication without a negative impact on workflow. So this is a really powerful study, and I think is meaningful to all of us as we look for ways to, improve the safety of our patients and improve our own communication. The graphic up here is Miller's triangle, which shows, just when you look at educational studies, the impact. If you can get to the top where you show that what you're teaching actually improves care, that is really what you're hoping to achieve ultimately. And this work actually received the same safety and quality award I just mentioned in 2016. So just take a moment and say, all of this work involved hospitalists. It did not solely involve hospitalists. Certainly for solutions for patient safety, that involves people from all over the hospital, but hospitalists have been involved. So I think they're really important things to reflect on what we've been able to accomplish in this field. So next we're going to move into explaining the criteria for ABP certification in pediatric hospital medicine. And as we do that, I'd like to just take a moment to discuss the evolution of our field. So we were first described in 1996 by an internist named Bob Wachter. He's currently the chair of medicine at UCSF. Since that time, the field has grown both in internal medicine as well as pediatrics, and we now have an estimated 4,000 to 4,500 pediatric hospitalists in the United States at both community and university-based sites. So it's really a very rapid growth, which has been influenced by three major factors, which I'll talk more about. We have a changing population of the types of patients that are in the hospital, changing type of population that are being treated in outpatient practices, and then really an influence of U.S. healthcare policy and economics that is driving a lot of this change. So in terms of our inpatient population, many of you that rotate through our service know we have pretty sick patients in general. Over time we've had a higher acuity in terms of patients that are seen in the hospital. Now, many acute pediatric conditions that would have been treated in the hospital in the past are actually treated effectively in the outpatient setting. In addition, effective vaccines have really reduced or even eliminated certain conditions that used to be quite commonly seen on the pediatric ward. Instead, now what we're seeing on the inpatient side are really serious complications of common problems. I think those examples from the PIVVOT study that I mentioned are great examples. We're talking about complicated pneumonia, complicated appendicitis, osteomyelitis. But as you can see, through advances in medicine, we're able to actually move those into the outpatient environment sooner rather than later. We're also seeing multiple comorbidities, complex chronic conditions, as well as I think across the country we have a bit of a mental health crisis right now, so acute mental problems also on the inpatient unit. And then finally, technology dependence and special healthcare needs. So similar factors are changing what our office-based pediatricians are seeing in the outpatient environment. Vaccines there have also made a difference. And then, as I mentioned, care for many conditions has moved into the office. And as our technologies have advanced, previous life-threatening conditions are now being managed as manageable chronic conditions in the office setting. Finally, and those of you who are in the outpatient environment know this much better than I do, but the ABP, as they were exploring making us a specialty, found that the outpatient practice is really now seeing a lot more time-intensive developmental, behavioral, and mental health problems in practice. So a decade ago, a quarter of visits were for those types of problems. Now that is over half. So all of these things are, making it more difficult for a provider who's spending a lot of time in clinic with these intensive problems to come and see patients on the inpatient environment. From a healthcare policy and economic standpoint, payers are moving from fee-for-service, which is really a volume-based mechanism, to global payment mechanisms, value-based reimbursement, with a goal to improve the quality, access, and outcomes of care provided to patients. And this movement really just adds to the pressures on outpatient physicians to see more patients, to achieve quality benchmarks in their practice, and it also pressures inpatient physicians to pursue more efficient care. So those pressures are really, moving both inpatient and outpatient physicians to dichotomize a bit, whereas it used to be one physician that would see both inpatient and outpatient. Now that pressure is leading to more of hospitalists and outpatient physicians as separate branches of practice. What about outcomes? So there have been several studies that have looked at outcomes of care by hospitalists as opposed to general practitioners trying to do it all. Those studies have been fairly consistent in showing decreased length of stay, decreased costs, and decreased resource use by at least 10%, without any associated 7-day readmission or mortality. And here's a list of those studies. In addition, there have been studies that have looked at guideline adherence as sort of a marker of quality. And there have been several studies that have showed that hospitalists tend to better adhere to AAP practice guidelines. In specific areas, we can look at hospitalist impact in surgical co-management. And several studies have looked at surgical co-management for spinal fusion. And the results are, if hospitalists are used for for medically complex patients, there's some definite improved outcomes in terms of length of stay and decreased resource use, such as decreased days on TPN and decreased laboratory testing. Patient and PCP satisfaction. This is another area that the ABP looked at when considering specialty certification for our field. And they have a periodic survey through the AAP which shows fairly consistently that PCPs referring patients to hospitalists reported high values of satisfaction with their care. That certainly is not to say that all care is perfect and there isn't necessarily room for improvement, but that is an encouraging finding. In addition, 2/3 of those respondents said that hospitalists improve the quality of their care for inpatients because they're immediately available and work full-time with hospitalized children. And then some surveys of patients and parents also reported high levels of satisfaction with care provided by hospitalists following referral by their PCP. What about hospitalists' role in education? Well, I think we can ask our trainees. The studies that have been out there have shown a generally very positive perception of hospitalists in terms of the quality of their teaching, but we really don't have high-quality educational studies of outcomes of teaching by hospitalists versus non-hospitalists. The other thing that the ABP noted in their decision to pursue subspecialty certification is a unique role of hospitalists within a systems-based practice. And this is directly from their article. Traditionally, pediatricians are trained to practice within healthcare systems to provide the best care for individual hospitalized patients. Hospitalists have the responsibility to address health system issues that affect the broad population of hospitalized children. For those of you that are hospitalists in here, hopefully that resonates with you, but I think, standing from the vantage point of being a solely inpatient provider, you have the opportunity to see where there are gaps in care that may be affecting more than one patient and how we might be able to address those gaps. So here's an example from my own work at Cincinnati Children's. We were noticing among some of our orthopedic patients that were medically complex that there were several children that were developing postoperative pneumonia. So this is a cervical spinal fusion in a child that had pneumonia postoperatively. And as we thought about our typical care algorithm, most patients had one of these devices in the upper left in their room. You'll recognize that as an incentive spirometer. But an incentive spirometer is not terribly effective if you're neurologically impaired or under the age of 6, right? You're not going to be able to participate and use that effectively. So to really solve this issue, when we noticed that it was the children with neurologic impairment or the young children that were running into issues, we were able to partner with our pulmonologists, respiratory therapists, as well as our orthopedic partners, of course, to develop a different algorithm for those patients. And so this device on the bottom, we came up with. It's actually studied in the literature, but we were able to kind of put together the pieces that made this work well for us at Cincinnati Children's. So this is a breath stacking device. There's a one-way valve. You can see a little arrow on there that shows which way the valve is flowing. An anesthesia mask and a manometer to tell you if you're achieving effective pressures. So with this device, we'd have children with neurologic impairment have serial inspirations to open their lung volume, possibly generate a cough, but overall reduce the amount of atelectasis. So we incorporated this into our care pathway for children after major surgery. And we were able to find that for those children that did have underlying medical conditions or neurologic impairment, we were able to reduce the amount of time these children required oxygen from about 22% to 6% following the intervention. These are small numbers and it's small scale, but we really seem to have solved this issue of pneumonia after surgery simply by thinking differently about how we were providing that preventive care after surgery. Another example is about VTE prophylaxis. So we had a couple, rare but very serious cases of PE or DVT in our patients postoperatively. And a bunch of us wondered, how can we approach this problem? At the time, there were no published guidelines for which patients really required prophylaxis for venous thromboembolism and which did not. And so from this bedside recognition of an issue, we're able to put together a team with collaborators from multiple specialties to really look at this problem, define it. We developed a surveillance system to really see what our rates of thromboembolism were. We developed a standardized care guideline, implemented that guideline, and are continuing to work on measuring the impact of that work. So this is another example of the hospitalist being able to move away from the bedside of one patient and take that broader, more global view to try to improve healthcare systems. In the current state, pediatric hospital medicine services are quite prevalent. I was actually surprised by this statistic. 98% of hospitals that have academic departments at pediatrics have a pediatric hospital medicine service. And 100% of hospitals listed in the U.S. News and World Report Honor Roll of Children's Hospitals have dedicated hospital medicine services, which I think says a lot about how far our field has come in a very short period of time. So as the ABP really considered our application for subspecialty status, these were the final findings that really drove them to approve the application, which is they felt that hospice care has a demonstrated positive impact on children's health through increased efficiency, lower costs, improvements in measures of care quality, adherence to guidelines, generation of new guidelines, and in patient and parent satisfaction. In addition, the Board of Pediatrics felt that PHM was likely to accelerate improvements in innovation in QI science and enhance development of leaders that are skilled in addressing child health issues and safety in the environment of a complex healthcare system. So with that, the ABP recommended we become a subspecialty, and then the American Board of Medical Specialties, ABMS, officially recognized our subspecialty certification in October 2016. And as many of you in the room may know, we will have our first exam offered in November 2018. There'll be 2 avenues available for this subspecialty certification, either the practice pathway, affectionately termed as grandparenting in, or the training pathway, where trainees will undergo a fellowship in hospital medicine to be eligible to take this exam. The criteria for taking the exam is going to include consideration of several types of practice, so primarily for the grandmothering pathway or grandfathering pathway. Practitioners need to demonstrate a broad clinical practice, and this is important because as hospitalists, we take care of lots of different types of patients. We want to make sure that we're outside the scope of the general pediatrician, but we are familiar with multiple types of conditions that affect hospitalized children. So a direct quote from their article is, "The clinical domain of PHM is generalist in nature, being neither organ-specific nor disease-specific." And then other considerations include system-based expertise and academic skills to really move the field forward. System-based expertise lends itself in many different ways, recognizing and adopting high-value care models, improving flow throughout the hospital, so helping to reduce patients that are boarded in the ER, perhaps by figuring out ways to get them discharged sooner, working in transitions of care, including handoff, readmission, and transition, and patient safety. This system-based practice, I think, helps me think about hospitalists' roles as leaders in the hospital. When you think about this concept of meta-leadership or leading across disciplines, leading down and leading up to hospital administrators, hospitalists are really uniquely positioned in that we collaborate with all different specialty groups throughout the hospital and need to be adept at speaking to different groups and speaking up to find the resources we need to really make this work possible. So to that end, you may or may not recognize several prominent hospitalists in our field. On the left is Steve Muthing. He's at Cincinnati. He's the Chief Quality Officer. He's one of the founders of Solutions for Patient Safety. Next to him is Patrick Conway, who recently left CMS to become the CEO of Blue Cross Blue Shield of North Carolina, but previously he was the Director of Healthcare Innovation and Quality for the Center for Medicaid and Medicare. Steve Narang is CEO of Banner University Medical Center. He's a pediatric hospitalist, if you all didn't know that. And then Nancy Spector at Drexel University is the Executive Director for the Executive Leadership in Academic Medicine program. We are fortunate to have representation in several of our hospital medicine national organizations. There are 3 main organizations that really lead our field. It's the Society of Hospital Medicine, the Academic Pediatric Association, and the American Academy of Pediatrics. Dr. Sandy Gage is Executive Chair of the Society of Hospital Medicine Pediatrics Special Interest Group. I'm one of the co-chairs of the APA Hospital Medicine SIG. And we actually have a representative from Arizona AAP in our group as well, Rick Engel. The Consortium of Pediatric Hospital Medicine has 2 members from each of those main national societies. And this year, just because of the way that things fell, we actually are very represented at Phoenix Children's because both Dr. Gage and I are part of that group. We have several hospitalists here locally involved in leadership. So you recognize all of these folks. We're represented in quality, Chief Clinical Integration Officer, clinical documentation improvement, and utilization management. We also have several folks involved in educational leadership roles. You'll recognize our residency program director, our hospital medicine fellowship director, and then we have clerkship directors for 3 of the main medical schools. And I apologize, I put Dr. Wall's affiliation. She's actually with Mayo Clinic rather than University of Arizona. In terms of educational impact, I think those of you that have worked with us know we really reach learners at all different stages of all different types. All of the residents come through our rotation as part of their inpatient learning experience. We have students from 5 different medical schools. We are proud to host our chief residents as they have their initial attending experience on our service. And we have a hospital medicine fellowship as well, 2 fellows per year. In terms of our scholarship representation nationally, we have a representative on the editorial board of Hospital Pediatrics, as well as a section editor of the main textbook in our field, Comprehensive Pediatric Hospital Medicine. So all this leads me to share our strategic plan with all of you. I think our overall vision as a division is to become a premier clinical and academic pediatric hospitalist division through a constant focus on getting better. Our mission is to provide excellent, high-value care to hospitalized children, as well as excellent education to our trainees. It's important to train the next generation. And our work values include putting the patient first at the center of everything we do, working as a team, and then again, that constant focus on getting better. We have 3 strategic pillars. Those are focused on value, quality, and safety. And what I like to refer to, the last one, is our people pillars. We want to be a place where people are excited to come to work, where they feel like they can grow in their careers. So that first strategic pillar is the scope of practice. We'll focus on areas where we add value and support high-value models. The second pillar, we will continuously improve the quality and safety of the care we provide. And the third pillar is we will strive to be a division where people want to work, where they achieve personal and career satisfaction. And as we put this plan together, I think all of us realize there's some critical enabling things that need to happen in order to make this vision a reality. That included really ensuring that our clinical job description is sustainable, and we were able to benchmark our effort here as compared to national programs and make sure we're in alignment with that. Really developing clear expectations, goals, and performance evaluations, and then seeking out high quality opportunities for faculty development and mentorship for everyone in our division. Finally, we're working still on data and administrative support to really bolster our ability to measure outcomes from the work that we do. Our academic areas of focus as we move forward include transitions of care. The hospitalists in the room are acutely aware we are piloting a brand new shift model right now to enable really high quality handoffs from one physician to another. We're also focused on hospital to home outcomes, and Dr. Gage in our group is part of Project Impact that looks at a bundle of interventions to improve communication from hospitalists to PCPs at the time of discharge. We're also interested in pursuing high value care models, as I mentioned. This may include surgical co-management, similar to the model that I mentioned. We're focusing on standardizing around evidence-based guidelines and really measuring outcomes when we are utilizing those guidelines. Finally, we have a focus on improving communication. We've applied to be a site for the family-centered IPASS study. So this is utilizing concepts from that early IPASS work and moving it to the bedside for family-centered rounds. And finally, patient safety. Our patients come first, and we want to make sure we provide the safest possible environment. So working to make that happen. I am at the end of my slides. I'm happy to take questions. These are my 2 sons, the youngest which is responsible for my laryngitis right now, but he is worth it, I think. Questions? Asu. Yes, that is an excellent question. So obviously there are quite a lot of hospitalists. Currently we have 34, they're non-accredited fellowships. They will become accredited within the next year or so as part of that work. And I think more programs will open up more fellowship spots as well. But the ABP, as part of their work, noticed that there's 200 to 300 hospitalists entering the field every year, so certainly our fellowships are not equipped to handle that volume. So I don't think there's going to be necessarily restrictions placed on who can become a hospitalist or from that perspective. I think it's possible that some academic programs may require board certification for faculty positions in their academic sites, but that may be different for different types of sites. So a good question. I think the workforce issues we haven't quite figured out yet. And I think a similar thing happened with pediatric emergency medicine. So that's probably the closest corollary I can think of to another recent entry into new subspecialty status. And there is certainly room in multiple pediatric emergency departments for non-board certified providers, so that there may be a similar model that emerges within our field as well. Yes. Yeah. Yes. Well, I want you to take heart. One of the executive vice president for the American Board of Pediatrics is a medicine pediatrics trained person who's the former program director at Duke University. And we actually have a medicine pediatrics, or joint medicine pediatrics representative on the board that's coming with PHM, Dr. Jennifer O'Toole. So I think there is a consideration of these issues, and there actually are some initial models of how we might be able to welcome medicine pediatric graduates into our fellowship program so they can be fellowship trained essentially in both specialties. Right now, there isn't a separate specialty in hospital medicine and adult. There isn't the same model. So it is interesting. I think it probably will be an individual decision about what your goals and practice are and how to best accommodate what you'd like your practice to be, and sort of would a traditional fellowship help you get there, or are there other ways to get there? John?
If you compare Phoenix Children's Hospital Division to all the other children's hospitals and all, and you were to rank like the most advanced hospital division as 10, and like 1 would be the least good, where would we stand, and what would be some of the things that like we're doing better than a lot of places? What are the things that we still have to move up to get to where we'd be competing with others?
Great question. So I'm going to go back to sort of our vision statement that we want to be a premier division. So I'm going to venture to say I don't think we're totally premier yet. I think we have a ways to go, and just to really bolster our academic approach to our work and having some more scholarly productivity to share with the rest of the field to help move the field forward. So that's really where I think it is. It's doing the work that we do, but with that mindset of how can we make this better, and how do we know that a change is an improvement? So can we measure what we're doing to ensure that our changes are going to make things better? So I think we're close. The steps I see to helping us get there, I alluded to in terms of that critical enabling infrastructure. So I think we do need a little bit more data administrative support, and that's something that we continue to work with the institution on, helping us find data so we can measure what we're doing, but then also working to develop our faculty and obviously train our fellows to do high quality work.
So is it your goal as a division chief that all the hospitalists eventually will be board certified hospitalists?
I think I have not personally committed one way or the other. I think to date, our rate of hiring has exceeded our ability to say we only want to take fellowship graduates. However, I think to move in the direction we want to go in terms of being a more academic division, it is really important to hire people with the skill set to do that. And so increasingly that's going to be fellowship graduates, or folks that may have taken a path that several of us who are a little more senior have taken, and pursuing graduate work outside of a formal fellowship to be able to do those kinds of work.
Does that kind of take away from the power of the certification process if people aren't certified? Then what's the point of that?
I understand that question. I think it's relevant also for emergency medicine and other types of specialties. So what I think will probably happen is what I alluded to for what I think will happen nationally, which is strong academic programs will continue to only take folks that had that additional training. And so that will be really meaningful for folks that want to work at, premier programs. I think there is also the possibility that those strong academic programs, they may have faculty positions that have support for research and quality and other endeavors, and they may have purely clinical positions that don't have that type of support. And again, that'll make one position more attractive to fellowship graduates as compared to the other, but folks will be able to sort of self-select in terms of what career path do they want. Do they want to just be taking care of patients, or do they really want to be driving the field forward through innovations? And that will help them determine that a fellowship is likely the best option.
I guess I'm still kind of confused that, I understand a fellowship program, but the board certification is different. You don't have to be fellowship certified or gone through a fellowship program to take the board certification, correct? Your grandfather has so much
Yeah.
training. And so, to me, I think most other specialties that are relatively newer have really pushed, certainly the ABP has pushed to have to be board certified in order
Sure.
to practice this specialty.
Do you know there's a timeline around the grandfathering?
I didn't know that.
I'll let her answer that, yeah.
Yeah, grandmothering is my preferred term. So within the first 7 years that it's offered, it is possible to be grandparented into the subspecialty. So you have to apply in order to do that, demonstrate that you've had a significant clinical practice to support that application. So that includes demonstrating broad clinical practice. And it has to be, I won't go too much into the details, but you have to have a significant portion of your time in that care of hospitalized children. And then you can apply to be eligible to sit for the exam through that pathway. For our residents, it's important to note this year's graduating residents, if you go directly into practice July 1 after graduation, you can still potentially enter the field through the grandparent mechanism. You may not have known you were as senior as you are, but it would be possible. Beyond that, really to be board certified in hospital medicine, you'll need to pursue a fellowship. Other questions? Okay, we are done early. Thanks.